Okay, so let's speak here about kind of just wrapping all of this up. We said that expiration is normally a passive process. We talked about this last time. It is basically the relaxation of our inspiratory muscles. When they go back to their original state, they sort of just relax. So that means the diaphragm gets back to that nice dome-shaped curvature. The external intercostal sort of relax back down. And that is changing or decreasing the volume of the thoracic cavity. But it's not relying on any active contraction of other muscles, right? For normal, passive, or quiet expiration. For active expiration, on the other hand, or forced expiration, we do engage the expiratory muscles. So that's the internal intercostals, as well as the abdominals, specifically the rectus abdominis muscle. And all that does is it kind of makes the change of the thoracic cavity more forceful. So it just kind of forces the volume of the thoracic cavity to decrease, as opposed to just passively allowing those inspiratory muscles to relax. All right. Okay, let's look at a few practice questions here, and then we will call it a day. Okay, so I'm going to launch a poll here. Okay, last few seconds. All right. So between breaths or at rest, some air stays in the lungs. So much stuff in over here. What is the term for that volume of air? And so there was a lot of response for C, but actually the combined response for the other options was more than the amount of people that selected C. So there's a misunderstanding here. So we talked about this functional residual capacity. Okay, it's the fact that there's some air left in your lungs after quiet inspiration. So after you're just sitting, taking a nice, normal, quiet breath in and out, after you breathe out, there's more air left in your lungs. And we talked about the purpose of that air being left in your lungs. It's to create the pressure that accommodates airflow in the opposite direction. If we were to completely empty out the lungs, there would be no pressure there. But remember, we need to have a gradient. And so there must be some pressure, some air left in your lungs to facilitate that gradient, which facilitates outward airflow, okay? And then inward airflow again. So there's never this complete emptying of the lungs. There's the functional residual capacity, which is the combined amount of volume that's left in your lungs. It's actually made up of two other volumes, which we'll talk about the next time we meet, but it's all the air left in your lungs at the end of a quiet breath. Okay, let's look at another one. The answer here was C. Oops. Okay. So a lot of response for A, atmospheric pressure is approximately 760 millimeters of mercury. Relative to atmospheric pressure, the intraalveolar pressure is 0 at rest, but what is the actual absolute intraalveolar pressure at rest? And so again, this question brings up that conversation of relative versus absolute pressures here. And so the correct answer is A, 760 millimeters of mercury. In other words, it is the exact same as atmospheric pressure. But in terms of the relative value, right, the relative value is going to be 0, the absolute value. The fact that there is a pressure in your alveoli, it's never 0 in actuality, but relative to atmospheric, we describe it as 0 because we zero out that atmospheric pressure. Okay, and in terms of just looking at the gradient, it doesn't really matter what the value is. If it's 0 in the atmosphere and 0 in your lungs, that's no gradient, so there's no airflow. And that's just a way to represent that value relative. But in actuality, it's about 760 in the atmosphere. It's also about 760 in your alveoli at rest. And again, there's no gradient, there's no flow. Okay, so for those of you who selected other responses, please go back and make sure you understand why this one was A, why the atmospheric pressure is equal to the intraalveolar pressure at rest. All right, let's look at another one. All right, let's take a look. So a lot of response for C. In normal breathing, keyword normal breathing here, right? Normal breathing. Which muscles contract for inspiration and expiration? So we said during normal, quiet respiration, normal breathing, inspiration is done by the external intercostals and the diaphragm. Expiration is done by nothing. No muscles are actively contracting to bring about expiration. It is a passive process and it relies on the recoil of those inspiratory muscles, okay? Now, if I change this question to say during forceful respiration or during forceful breathing, then the internal intercostals would be the correct answer, okay? But for normal quiet respiration, we do not engage the the internal intercostals or the expiratory muscles. And I want to make it clear, they are still described as expiratory muscles. If they were to contract, they would still result in expiration. But the reality in our physiology is that in order to expire, we simply just relax the inspiratory muscles, and that passively changes the shape of the thoracic cavity and facilitates the volume change, which facilitates the pressure change that allows air to flow out of the lungs, okay? If I want to forcefully expire, and again, I encourage you to try doing this, try to forcefully engage your abdominals and push air out of your lungs, that will call on those expiratory muscles, but not quiet respiration. Okay. I hope that was clear. Let's see what questions we have as we kind of wrap up here. So the answer for this one was inspiration, external intercostals and diaphragm, and then expiration, nothing. Okay. Oh, there's one more question. Let's look at one more in the remaining minute or so. All right, last few seconds. All right, so an overwhelming response for A, during regular breathing, what is the intrapleural pressure? And it is always, 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 always negative, okay? There should never be air. It should always be a negative pressure, sort of a suction that we described, in order to keep the pleural, the parietal pleura, tightly adhered to the visceral pleura. In other words, keeping the thoracic wall tightly adhered to the lung itself. And so there should never be the introduction of air in that space.